So now that we've done our assessment, we've identified that at-risk patient. What are our next steps, Joe? How do we really go about sort of managing these patients?
Yeah, so I think management really, your first line is benzos. Down here, I know that we use chlordiazepoxide a lot.
Yeah.
Although in the literature, diazepam is also quite frequently cited. So both of these agents have got quite significantly long half-lives, and so what this means is that you get a bit of a more tailored and kind of gradual approach to your therapy, as opposed to, say, giving somebody who's acutely withdrawing a shot of lorazepam, which has got quite a short half-life. Although the caveat to that is these agents, chlordiazepoxide and diazepam, can be at potential risk of build-up if you've got really, really significant liver failure, renal failure. These patients are really comorbid, and so you have to take that into consideration. And so I think there are certain areas where guidelines might suggest to use more quicker acting and short half-life medicines like lorazepam, and then more continuously dose it. But I think the issue is with that is you're more likely to get withdrawal side effects.
So we were talking before, weren't we, and sort of said, in my practice, I've never given lorazepam for someone withdrawing. And it was so it's a bit of an eye-opener when we were sort of reading this. Actually, the literature says that I should be giving those high-risk patients, those cirrhotic patients, lorazepam, and I just don't, because it's the CWAR chart is so easy to do. Chlordiazepoxide is something that's quite well known in the UK, and lots of nursing colleagues are very comfortable using it.
Lots of experience using it.
Whereas lorazepam, it is that seizure drug, isn't it?
Yes.
It's that we normally give 4 milligrams as a big bolus, and actually, obviously, you're going to be using smaller doses. You might be using oral doses as well. I think it's just an experience issue largely.
I noticed that you talking about CWAR. It's not something I use all the time in my practice.
No.
What is CWAR? How do we incorporate it into our practice? What does it mean? And all of those questions.
See, I'm going to have to quickly check, so I don't going to get the words wrong. So CWAR is the Clinical Institute Withdrawal Assessment of Alcohol scale.
Probably why they called it CWAR.
It doesn't quite roll off the tongue, but it's a very useful scoring system. It's quite a hefty chart, and there's about 10 things that are scored from, and it's basically based on those symptoms that defined by a DSM, and you get certain points in each category for it in an overall CWAR score, and I think it's out of 50 from memory. He's going to have a quick look down there. 67, it says on the little CWAR chart there. Close enough, yeah. And basically, if someone's got a CWAR of, I think it's sort of 20 to 50, they get X number of chlordiazepoxide. And if they have a certain lower score, then they get a certain number of chlordiazepoxide. So it's very just straightforward, depending on local formulary type guidelines, that your CWAR score correlates to the degree of withdrawal that you're currently experiencing, and therefore the degree of chlordiazepoxide or whatever suitable benzo that you decide to use, the amount of benzo that you require to prevent you further withdrawing.
Yeah, so it's interesting. So you don't often get a kind of clinical decision making tool that actually gives you a tailored approach to.
No, it's really good.
Yeah, so that's quite beneficial actually, and I think very frequently and successfully used.
Yeah. The other one to be aware of is the Glasgow one, which is, I think it's the Glasgow Modified Alcohol Withdrawal Scale.
Okay.
He says.
Let's go with that. Sounds legit.
It might be wrong. If it is wrong, I'll correct it in the show notes. But I think that's what it's called, and it's very similar concept. Obviously, comes from Glasgow. Yeah, very similar to the CWAR. You get a scoring system. You get a score which says how much benzo you should have.
What we wanted to also just briefly touch on are some differentials that are within that same group as well.
Yeah.
So you sort of alcohol-related disorders or presentations as well, because you could have these concurrently going on, and frequently concurrently going on, and you will see these in the emergency department in your practice all the time. But also just to make sure that you'll keep casting that broad net, as Matt said. So, Matt, do you want to talk about the first one?
I think probably the first, outside of withdrawal, the big thing that comes to mind is Wernicke's, eventually into Korsakoff. So Wernicke's is essentially due to thiamine deficiency, so that's vitamin B1, and so it's a chronic thiamine deficiency, and it's often seen in patients who have alcohol excess. It can also be seen in other things, so eating disorders springs to mind. like bulimia and anorexia and things. It does happen in those. Other conditions can cause it too. And essentially what happens is that Wernicke's is sort of the first stage, it's the early stage, and it is reversible. Right. It generally presents with things like confusion, a bit of ataxia, horizontal nystagmus. You normally get more than 3 beats, about 6 beats normally. You can get some ophthalmoplegia as well, so your eye movements are affected. But yeah, I think this key, just to reiterate again, is that Wernicke's is reversible. Okay, so you want to get these patients on high dose vitamins, high dose B vitamins. So Pabranex is the brand name that springs to mind. There may well be other brand names, but I've never come across them in my practice.
Other brands are available.
High dose vitamins, Kellogg's cereal. And eventually that will lead to, if untreated, Wernicke's will lead to Korsakoff's, or sometimes called Korsakoff's dementia, Korsakoff syndrome, which is essentially a progression of the disease, and it is irreversible at that stage. Key features here, again, you get your ataxia. You start to develop a bit of neuropathy, as again due to the B1 deficiency. And classically, you get what we call confabulation, which is where, because there's a bit of dementia and there's the memory loss, patients, for whatever reason with Korsakoff's, essentially make up stories to fill in their memory gaps. And it's really interesting. I've only seen it a couple of times, but it's really interesting to have a conversation with those patients, because if you keep them talking long enough, you will eventually find a gap in whatever they're telling you about, sort of say their journey to hospital or whatever. And they would just fill it with utter nonsense.
Okay.
But it makes sense to them, and it's just very interesting to see. So I would highly recommend doing a quick internet search for Korsakoff's confabulation, because it's just very interesting to see, and I don't think I could adequately display it in a podcast.
And I guess actually, if you don't have that in your differential and you don't spend the time actually trying to get that, that's something that you're going to miss, isn't it?
Yeah.
Because a lot of patients live and do things very, very differently to whatever clinician may or may not be assessing them, and so that you might think that whatever that is normal.
Yeah.
And actually, it's a presenting symptom of a progressing organic brain issue.
Yeah. So that's Wernicke's, Korsakoff's, bismuth B1 deficiency. Joe, any other big alcohol issues?
Yeah, so I guess the hepatic encephalopathy is really is something I've seen a few times. I basically went along around in my first couple of years of being a clinician, trying to find someone with liver flat. Because it's always in your OSCEs, isn't it? It's always, you go up the arm and then you check for your palmar erythema, and then you're doing this, and then you flapping tremor. So,
did you not believe it existed until you
no, but I have seen it a couple of times, and it's quite difficult to not be like, yes, when you get a really good clinical finding. Do you know what I mean? And so encephalopathy, due to an inability from hepatic dysfunction of the individual to clear those proteins, and predominantly the main one we're concerned about is ammonia. So leads to increased ammonia, and then we get some inhibitory effects from that, and eventually cerebral edema. And then, of course, when you're thinking about cerebral edema from there, you're thinking about all the dysfunction that comes along with that. So your drowsiness, and that can lead right down through all the CNS effects to actually coma. Yeah. But before that, you may actually see skin color changes. You may see kind of that sort of drowsiness, confusion, and that's where that flapping tremor sort of comes from. And so the diagnosis is clinical, although we can measure ammonia. I don't have much experience in that. But do you do that?
A massive faff. It has to be taken on ice.
Right. Okay.
So you've got to, I can't remember I think it's a gold top, but you've basically got to call the lab and say, I'm going to bring an ammonia down. And then you've got to call wherever the ice is kept in the hospital, which used to be ED. Sometimes there would be ice in ED. Sometimes there'll be ice in orthopedics. Some surgical units have it. Labs have it.
Do you not have like a big bathtub of ice for your rapid ice cool downs for drug overdoses?
No, we don't. So you then have to find the ice, get the ice to you, take the blood from the patient, which is often a bit difficult because these patients are either a bit fighty or a bit no veiny, and then get it to the lab, I think, within 20 minutes of you taking the sample.
That's pretty.
And then basically what happens is the gastro will basically come round and they'll go, oh, the ammonia's raised. Yeah.
Okay.
And as you say, it's a clinical diagnosis.
Right. So we don't really need these tests, but this is something that
may be helpful. A normal ammonia certainly might be helpful.
Yeah. I think something that's more helpful is actually to rule out cerebral edema, isn't it? So CT head, if you're really, really concerned, can be something to think about. How do we treat this? So supportive in several ways. We can also treat with lactulose, so basically alters the microbiome in the gut. So and thereby actually what we're doing is kind of forcing a clearance of the ammonia that's been built up, and the ammonia producing bacteria from that. So, but really, I think that's kind of thinking down the line, isn't it? With these patients, and it's not going to be part of your initial presentation.
No.
And initial management. It's probably something that you're going to be liaising with specialty teams to do.
Yeah, you might start a bit of lactulose if you're seeing the patient, but really, sort of, it's over like a ward-based setting. Yeah. You're aiming, I think it's 3 stools a day, it says, pulling from the depth of F1 medical knowledge. I think it's a certain number of stools a day you're targeting, but as you say, it's more of a ward-based ongoing care thing where you fart about with the lactulose doses, and they're often on BD lactulose. Sometimes they'll be on a bit more, just trying to get that through. You may often give them phosphate enemas as well, just to clear that bacteria. Yeah, somebody have a Google of how many stools a day required in a bacterial encephalopathy.
Yeah, tweet us back.
Yeah.
We want some stool stats. Hashtag stool stats. All right, Matt, so that's pretty much all we've got to talk about, isn't it? Yep. Do you want to just summarise for us those main points then?
Yeah, so we talked about alcohol withdrawal, gone through the key features. Basically, it's to do with the GABA and NMDA balance, and so the withdrawal features are basically excitatory CNS features, anxiety, nausea, vomiting, all the way up to hallucinations and seizures. The key really in your assessment is to identify patients who are at risk of it. I think that's one of the keys. Management-wise is about giving them benzos, using your CWAR or your Glasgow Modified Alcohol Withdrawal Scale, giving the appropriate amount of benzos, keeping them safe. And then we touched on other alcohol-related issues, talked about Wernicke's, which is B1 deficiency. Wernicke's itself is reversible, often presents with ataxia, confusion, nystagmus. Korsakoff's is not, which is the dementia aspect, where confabulation is the key feature. And then we touched on hepatic encephalopathy, which is due to essentially a build-up of ammonia causing confusion, possibly cerebral edema as well. The key feature there is stool management, and you're going to tweet us some stool facts, hopefully.
I think I've done quite a few witty sign-offs, Matt. So,
have you?
I mean, this is a pretty easy one. I'm sure you can bring up something.
It's an alcohol-related. Just thanks, Joe, for an intoxicating episode.
Oh, God.
Don't moan. You should.
Okay, thanks for listening, and we'll see you next time.